We have another fantastic issue this month, beginning with a pretty amazing article from the New England Journal of Medicine on intensive blood pressure control in patients with type 2 diabetes versus less intensive control. This is going to be an impactful article. Then, from JAMA Neurology, the cardioprotective glucose-lowering agents, that is primarily GLP-1s and SGLT2s, looked at for their effect on dementia. This is a systematic review and meta-analysis of randomized trials. Do one, the other, or both of these affect the development of dementia? Critical topic, followed by a discussion from one of the authors of the New England Journal of Medicine article on a randomized trial of automated insulin delivery in type 2 diabetes. Then an article from Diabetes Care on screening for MASH-associated advanced fibrosis. What's the best way to screen? And finally, the risk of urogenital infections in people with type 2 diabetes, initiating SGLT2 inhibitors in routine clinical care. This question about do SGLT2s cause UTIs keeps coming up. This article looks at this in an important way again. For our first article, we're going to discuss an article from the New England Journal of Medicine that is a big deal. And the title is Intensive Blood Pressure Control in Patients with Type 2 Diabetes. As all of us know, there's been some disagreement and disclarity about what the systolic blood pressure should be in patients with type 2 diabetes. The authors looked at patients 50 years of age or older with type 2 diabetes who had elevated systolic blood pressures and an increased risk of cardiovascular disease at 145 clinical sites across China. The patients were randomly assigned to receive either intensive treatment with a target blood pressure of less than 120, or standard treatment that targeted a systolic blood pressure of less than 140, and the trial ran for up to 5 years. The primary outcome was a composite of non-fatal stroke, non-fatal MI, treatment or hospitalization for heart failure, or death from cardiovascular causes. There were over 12,000 patients in the study that were enrolled from February 2019 through December of 2021. 45% were women. Mean age was 64 years. At 1 year of follow-up, the mean systolic blood pressure was 121 millimeters of mercury in the intensive treated group and 133 in the standard treatment group. During a median follow-up of 4.2 years, a primary outcome event occurred in 393 patients in the intensive treatment group and 492 patients in the standard treatment group, for a hazard ratio of 0.79. That is a 21% decrease in the primary endpoint. The incidence of serious adverse events was similar in the treatment groups, though symptomatic hypotension and hyperkalemia occurred more frequently in the intensive treatment group. John, your thoughts on this?
So I think this is a really question that we've been struggling for a while. And recently at a resident conference, someone said, what should our blood pressure goal be for a patient with diabetes? And I don't think there's that kind of quick answer, because we've gotten mixed messages. You go back to the Accord trial that looked at kind of 120 versus 140. People did about the same. That's a 15-year-old study. We've seen the STEP trial and the SPRINT trial that have argued against that. And I think we're kind of lost. And I think in a very kind of wise way, in certain ways, that the ADA has just kind of said, just make it 130 over 80. We'll split some of the differences in this. And I think this is a very powerful argument for 120, partly because the control group was 130, right? So it wasn't 160 or something like that. It was really good control. Now, it was a younger population than some of these other studies. It's a study done in China, so a little bit more of a homogeneous population. So you're going to take that with a little grain of salt, and only 60% of people in the high intensity group met that target. So I think, aspirationally, really aiming for 120. And I think if we get to 130, I don't think we should feel sheepish about that. And I don't think this should be something that an insurance company is going to say, Dr. Skolnick, you only had X number of your patients to 120. We're going to take some dollars out of your pocket. I think extending this data to people who are 82 years old, I think becomes a lot harder, because I think having symptomatic hypotension has far graver consequences for this. And I think when you look in all the annals of blood pressure trials for tighter control, people are on 2.8 to 3.6 medicines. And outside of a study for you and I in the room with a patient, patients are complaining how many pills they take. I think one of the arguments is I think we really need to embrace a little bit of combination therapy. That patient who's on 2 medicines in one doesn't think they're on 2 medicines in one. They just count the number of pills. So I think if we can use things that are combination pills, but the expectation really might be that average patient that we have with diabetes and hypertension, if we're going to put more time on the clock, we're probably going to have them on 2 to 3 medicines, and they're going to be on it for a long time. And I think we need to be mindful. Not everyone's going to meet that. And the people who have some symptomatology from the therapy, either we need to try therapies, or maybe we need to pull back, but maybe pulling back isn't 160. Our next article is from JAMA Neurology, and it looked at cardioprotective glucose-lowering agents and dementia risk, a systemic analysis and meta-analysis. So this study looked at randomized clinical trials comparing cardioprotective glucose-lowering therapy with controls that reported dementia or change in cognitive scores. Cardioprotective glucose-lowering therapies were defined as drug classes recommended by guidelines for reduction of cardiovascular events based on evidence from phase 3 randomized clinical trials impacting MACE. Data were screened and extracted independently by 2 authors. In August of 2024, random effects meta-analysis models were used to estimate a pool treatment effect. The primary outcome was dementia or cognitive impairment. The secondary outcomes were primary dementia subtypes, including vascular and Alzheimer's dementia, and change in cognitive scores. So the researchers put together 26 randomized clinical trials that were eligible for inclusion, and this included over 164,000 participants. There were 23 trials reported, and it looked at the evidence of dementia and cognitive impairment, including 12 trials that involved the SGLT2s, 10 that involved the GLP-1s, and 1 trial evaluating pioglitazone. There were no metformin trials identified. The mean age of the trial participants was 64 years of age, and 34.9% were women. So overall, cardioprotective glucose-lowering therapy was not associated with a reduction in cognitive impairment or dementia, with an odds ratio of 0.83. But if you look at the confidence interval, it's very wide, crossing 1, so you can't necessarily say that was statistically significant. Among the drug classes, though, GLP-1s had a statistically significant reduction in dementia, with an odds ratio of 0.55, a 45% reduction, with a confidence interval that lived on the side of 1. This was not found with the SGLT2s, which had an odds ratio of 1.2, and they do not have a number for the pioglitazone. Neil?
John, I think this is one of the most exciting things going on right now in medicine. So over the last few years, we've seen a number of observational trials that show that the GLP-1s decrease the risk of dementia, but those are observational trials. This is a meta-analysis of randomized trials showing essentially the same thing with about the same risk reduction. So almost a 50% risk reduction in the development of dementia. We know that this is a good group to look at because people with diabetes, as we've talked about many times on this podcast, have a higher risk of dementia than the population at large. And here we see GLP-1s having a significant effect. Why might it have that effect? There's a number of potential reasons. One, adverse effects of glucose on the production of beta amyloid. So lowering glucose, obviously the GLP-1s do that well, but so do the other diabetes agents. So it's not just that. There are other anti-inflammatory effects of the GLP-1s that are different than the other agents. So maybe that's what's going on. Whatever the mechanism, the data here is strong enough that there are right now two large clinical trials that are looking at semaglutide, the EVOKE trial and the EVOKE Plus trial, that are randomized, double-blinded, placebo-controlled trials with a specific primary endpoint of dementia. And if they show a positive effect, it will likely lead to an FDA submission and approval for treatment of mild cognitive impairment, which is one of the inclusion groups in the EVOKE trials, for mild cognitive impairment and mild dementia, which are really some of the scariest things that any of us face as we grow older. For our article this month, we're going to talk about an article published in the New England Journal of Medicine that is titled A Randomized Trial of Automated Insulin Delivery in Type 2 Diabetes. Joining us to discuss the article and its clinical implications is one of the authors, Davida Kruger, who is a nurse practitioner and director of clinical research for the Division of Endocrinology at the Henry Ford Health System in Detroit, Michigan. She is a past chair of the American Diabetes Association's Research Foundation and is also a past president, healthcare and education of the ADA. Davida, welcome back to our podcast.
Well, thank you for having me back. It's very exciting to be here, especially given the topic. I'm really excited. As I tell my kids, is that I may not know what to do with my cell phone and I may not know what to do with my computer, but I do know what to do with AIDs and anything related to diabetes.
You sure do, because so often when I read an article on AIDs, I notice that you're one of the authors. Can you give us some background on the importance of this article and why you all undertook looking at AIDs and type 2 diabetes?
I think you and I both agree that diabetes has expanded. Like when I first started, and I've been in the field for 43 years, we didn't have anything for diabetes that was type 2 diabetes. We had sulfonylureas, we had mixed beef pork insulin, we had nothing to offer, and we did not think it was a serious disease. We now know it is a serious disease and we need to be doing better. And so to be able to offer insulin pumps to those individuals who have type 2 diabetes, and there's no reason not to offer it for those individuals. That was the excitement about this study, is to say, how can we do better at what we do for people with type 2 diabetes?
That's right. And we know that automated insulin delivery has made a huge difference for people with type 1. How did you go about looking at this for people with type 2?
First of all, in the studies, and I think this is really important, in the studies, we really took people where they were. We didn't say that we want everybody to see a diabetes educator. We want them to have MNT. We want all that to occur. But the reality is everyone doesn't have it. And that should not be a reason for an individual to not be on a sensor and for them to be offered an AID. And in this study, we didn't do a lot of pre-education. We took people where they were and we said, hey, if you're taking a set bolus, we'll take you. If you're not yet taking boluses, we'll take you. If you're carb counting, we'll take you. And I think that's the important thing to understand, is that we met people everywhere they were and included them, and they did very well.
And I love that, because when we have research trials that allow us to generalize the people that are seen to the people we see in our practice, that gives more legitimacy to the results. So this was a randomized trial. Who were the people included in the trial?
You had to have type 2 diabetes. You had to have diabetes been on insulin for stable doses for 3 months. You had to have, if you were on SGLT2 inhibitors and GLP-1s, which we hope everybody is on, you had to be on stable doses of those as well. And I believe it was 18 to 75 years. And what was really exciting about all of the studies that I've worked on in type 2 diabetes is that we made sure we included people from all races, which we don't always do. And I think that was also very important. All socioeconomic status, all educational levels. It doesn't take a college degree to use an insulin pump.
Okay. And these were people on multi-dose insulin,
They
basal
could have
plus.
been on just basal insulin too.
Okay. And so they were enrolled in the study. They got some training, but I love the fact that it wasn't unbelievable amounts of training. What did the study show?
Basically, the study showed that no matter how you took your mealtime insulin, and people were taking mealtime insulin, whether it was just carb counting or whether it was just a set dose, the A1Cs came down between 0.7 and 0.9. And remember, it's only a 3-month study, so that's a very significant. But here's the other thing is there was greater time in range and without hypoglycemia. So better A1Cs, better time in range without hypoglycemia, and less diabetes distress, which I know is very important for. And I think we minimize how much distress diabetes causes people, but because this enhanced their lifestyle, they had less distress.
Yeah, it's so important. And for those of our listeners who care about p-values, I read this study again this morning, and that was a p-value of less than 0.001. So if there's any question here, this was real. There was some real
Yeah.
improvement in the people who had AIDs. And David, I love the point about diabetes distress because diabetes, it's 24/7 every day of the year, and it's a lot of work. And so that's an important endpoint. So what do you see as the clinical implications of this trial?
I think the clinical implications of this trial is that those individuals who have type 2 diabetes, as I believe everybody should be on a sensor. That's a right, not a privilege. But after we put them on a sensor, we should be offering people with type 2 diabetes an insulin pump. And one of the other things we saw was even those individuals who had done very well on GLP-1, their A1C came down the same as those individuals who were not on GLP-1, which reminds us that our job is not done just because we use incretins and SGLT2 inhibitors. So I think that was the other important thing that came out of that study. If you have type 2 diabetes, you should be on or be offered the opportunity to use a pump. So my feeling is once I'm starting to think insulin, it's the vehicle I use to deliver the insulin. And why shouldn't it be an insulin pump?
Davida, I always love talking to you. You're always pushing the edges of technology and science, and we all grow from that. Davida Kruger, thank you so much for joining us.
Thank you for having me.
This next article is from Diabetes Care, and it looked at screening for metabolic dysfunction associated steatotic liver disease related advanced fibrosis in diabetology. This was a prospective multi-center study. So the researchers conducted a planned interim analysis of a prospective multi-center study, including participants who had type 2 diabetes and/or obesity and metabolic dysfunction associated steatotic liver disease, MASLD, with comprehensive liver assessment comprising blood-based non-invasive testing, vibration-controlled transient elastography, and two-dimensional shear wave elastography. The risk stratification for advanced fibrosis was determined by a composite criteria of liver biopsy, MRI elasticity, or VCTE, depending on availability. Of the 654 patients, 87% had type 2 diabetes, 56% were male, 74% had obesity, 17.6% had intermediate or high risk of advanced fibrosis, and 9.3 had a high risk of advanced fibrosis. The area under the empirical receiver operating characteristic curves of non-invasive testing for detection of high risk were as follows. So the fibrosis or FIB4 score, 0.78, the fibrometer, 0.74, the fibro test, 0.78, enhanced liver fibrosis or ELF test, 0.82, and the SWE, 0.84. And then they looked at algorithms with the FIB score VCTE that showed good diagnostic performance for referral of patients at intermediate high risk of advanced fibrosis to specialty care and hepatology. An alternate of using the FIB score with the ELF test strategy showed a high negative predictive value, 88 to 89%, and a lower positive predictive value, 39 to 46% at threshold. The FIB4 score 2D SWE strategy had a negative predictive value of 91% and a positive predictive value of 58 to 62%. The age-adapted FIB4 scored threshold resulted in lower negative predictive value and positive predictive value in all algorithms. Neil?
John, this has become a really vexing issue because if we look at MAFLD, you have in total over 2/3 of people with diabetes who have, whether we call it MAFLD or the old name fatty liver. So this occurs in a lot of people, and a relatively small, but a large enough to be important number of them go on to develop MASH. And remember, the difference there is with MASH, you have inflammation, not just fat infiltration of the liver, but inflammation of the liver leading to ballooning and pathologic changes, which in turn then leads to different degrees of fibrosis, F1 through F4, then cirrhosis. This is important because MASH has become the second most common, it's on its way to being the most common cause of end-stage liver disease requiring transplant. The challenge, of course, when so many people have the early stages is how to select which people move on to hepatologists without overwhelming the system with too many people being referred on. And this is important because there are now treatments for advanced fibrosis, and there are more treatments that are on the way. So this study looked at different approaches, and it's pretty clear that the entry is the FIB4 score. And I was surprised actually that a higher proportion, over 50% of people, had a low FIB4 score than was my sense when I do it in the office. And that's great. So we, with a high degree of confidence, can not send on or do any other tests in about half the people with diabetes who we put through a simple FIB4 score, right? It has age, it has liver function, AST, ALT, and platelets. And we move 50% of people out of the algorithm, no other tests done, with a very high negative predictive value. Then for people who have a cutoff, they used above 1.3, those people go on to get a second level test. And those second level tests can either be a VTC, elastography, which I think most of us are pretty used to getting, and then with elastography using 8 kilopascals as the cutoff. If it's less than that, high predictive value, high negative predictive value that they don't have advanced fibrosis, they can be followed over time by us in primary care and endocrinology. If they have more than 8 kilopascals, they go on to see the hepatologist. The test here that was looked at, and I think we're going to be seeing a lot more of this that many of us are not familiar with, is the ELF. That stands for Enhanced Liver Fibrosis Testing. It's just a simple blood test, and it uses a equation based on 3 biomarkers to give a prediction of the likelihood of fibrosis. And the ELF, and they talk about different cutoffs, and I'm not going to go into the different cutoffs right now, they decided a cutoff of 9.2, also had a very good negative predictive value. So if you're in a place where it's hard to get elastography, or perhaps more conveniently a blood draw than a visit for a radiology test, an ELF can be used. So we have an algorithm that has a high degree of accuracy, starting with FIB4, and if needed, someone has a FIB4 greater than 1.3, either getting elastography or an ELF in order to decide who we can follow over time or who needs to be sent on to one of the specialists. Our final article This issue is from Diabetes Care, entitled The Risk of Urogenital Infections in People with Type 2 Diabetes, Initiating SGLT2 Inhibitors versus GLP-1 Receptor Agonists in Routine Clinical Care. It is a Danish cohort study. The authors investigated whether initiation of SGLT2 inhibitors compared with GLP-1s was associated with an increased risk of either UTI or what they abbreviated as GTI, genital urinary infections. Essentially, that stood for mycotic infections. This cohort study emulated a target trial. They included all adult metformin users who initiated SGLT2s or GLP-1s in Denmark from 2016 to 2021. As I say that, it is just phenomenal how good the ability to access information is in Denmark. And it's somewhat awe-inspiring to think that you could include all adults who meet these certain categories in all of Denmark. And because of that ability to access that data, the study included an enormous number of people, over 50,000 SGLT2 inhibitors and 27,000 GLP-1 initiators, with a median follow-up of 2.9 to 3.9 years. The estimated risks of UTI within the first year were nearly identical between GLP-1s and SGLT2s, around 10%. For mycotic infections, though, the one-year risk was elevated with the SGLT2s. It was 2% versus 0.7% with the GLP-1s, and that was a risk ratio of approximately 3. During the 5 years of follow-up, the relative UTI risk remained constant, meaning there was no difference between the SGLT2s and the GLP-1s. And the mycotic infections, while they became less over time, still remained quite a bit higher in the SGLT2s. John?
I think this is a fascinating thing. So in the 5th century, some physicians in India called diabetes urine like honey because it attracted ants. And it really wasn't until 1798, a Dr. Rollo, in kind of the Latin mellitus, urine that is sweet. So diabetes insipidus, if you tasted the urine, which thankfully we have moved away from as a bedside point of care test, was sweet. So intuitively, if it attracts ants 1700 years ago, we're going to say, wow, this is something that kind of makes intuitive sense. And you and I have been working together a long time. And I think when they first talked about these medicines coming out, we thought there would be a much higher rate of UTIs. And in fact, in 2015, the FDA kind of parked in the warning signs of this class of medicines that all our patients get about worrying about UTIs. So that's a bit of the background. Working in the hospital recently, a person with a bad pyelonephritis who also had diabetes, and the clinical question came up: does this person need to be off their SGLT2? And I said, going through the literature year over year, patients with diabetes do have an increased rate of having UTIs, but it's not necessarily higher with this category of treatment versus the other. If you dive into the literature, it talks about emphysematous pyelonephritis on a patient who's on this category or at that category, but that rare radiologic finding happens more often in our patients with diabetes. So our patients with diabetes with a suspected pyelonephritis need some imaging potentially to make sure they don't have this rare side effect. But what do we do now? Kind of baseline, we got a patient and we're treating their pyelonephritis, and we have them on an SGLT2. And we probably don't have them on an SGLT2 to make their diabetes appreciably better. The A1C response is always pretty modest, about 0.5, but we have it for all of these pleiotropic effects. And I think it really becomes difficult to say, you have diabetes and I'm going to take away this thing that might protect you from a litany of other things: heart failure, heart disease, progression of kidney disease, et cetera, because of this. But I think as clinicians, we also sit there and say the package insert says X. And what do I need to do? And probably there's enough literature that someone could hold up against their stance that these are okay. But I think there is enough evidence now that really would be nice for the FDA to change that or amend it in some way. So for the average clinician who takes care of the average person with diabetes, who gets a pyelo, who gets a UTI, what do I do? And this isn't talking about the mycotic infections. And even that person who gets one candidal yeast infection over a 3-year period of time, do you throw that use of that medicine out, or do you weigh it in the context? So I think an important article, and hopefully it will help with some different guidelines for you and I, who are very interested in using these medicines, but really want to use them with maybe a little bit more direction nationally.
John, before we close, I want to share some important news with our listeners. As you know, in addition to diabetes, we've been covering the full range of cardiometabolic conditions, and so this summer, our name is going to be changing to meet that consistent mission. Starting this summer, 2025, our podcast will be rebranded as Diabetes, Obesity, and Cardiometabolic Update. I know, you're already thinking, and you're right. The new name is Doc Update, Diabetes, Obesity, and Cardiometabolic Update. You'll notice this when the change is made on your subscriber feed. We'll have a new title and branding, same great information. For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
and keep learning.